Our next concept is steady state. Now, steady state is reached when the rate in is equal to the rate out, or when the values associated with a dosing interval are the same as those in the previous interval. And of course, achieving a steady state in the plasma is really a goal that we use in our maintenance dose equations. We're trying to achieve and to maintain a steady state. We refer to steady state as the plateau principle because ultimately as the drug rises in the plasma, we're trying to reach that plateau. Okay? The time to reach steady state is dependent only on the half-life of the drug. Very important to remember that only the half-life of the drug is what's going to predict the time that it takes to reach steady state. It's independent of the size of the dose and it's independent of the frequency of administration. You've got a very classic graph here looking at the rise to steady state. Again, looking at time versus plasma drug concentration. The goal here is to administer a drug at various intervals to achieve a plateau or a steady state in the plasma. And you'll notice I've added a couple of labels, and we will talk about the minimum toxic concentration and the minimum effective concentration and how that relates to this graph. But let's start first with the graph. If you start at time 0 and you administer a drug, let's say in this example you're giving 100 micrograms per mil of the drug. The half-life of this drug is 4 hours. So you're going to wait one half-life till the plasma level goes down to 1/2 of the original value, so down to 50, and then you're going to dose again with the same amount. So you're going to give 100 micrograms per mil and achieve a plasma level of 150. Wait a half-life, which is 4 hours, go down to 75, and then dose again. So now you're up to 175. Wait a half-life down to 88, dose again up to 188. Half-life takes you down to 94, dose takes you up to 194. And if you continue on that pattern, you're going to achieve a steady state. Notice that's achieved when you're oscillating between these 2 points, between the peaks and the troughs that you observe down here at the bottom. Okay? The peak values and the trough values. Recognize that all of your peak values are going to be obtained after you've dosed. The peak value, for example, after the first dose was 100 micrograms per mil. At steady state, the peak value is going to be twice that level, or 200 micrograms per mil. The trough values, of course, are all going to occur before the first dose. So kind of a silly question, what was the trough level before the first dose? The trough level before the first dose, of course, was 0. The trough level before the second dose, the trough level was 50. After that first dose was 100, but before the second dose, the trough level is 50. Before the third dose, 75. So all of these numbers in the bottom here represent your trough doses. And you can answer any question related to particular plasma levels, either before or after doses. Of course, at steady state, you're oscillating between two numbers, and those two numbers in this example are 200 and 100, back and forth at steady state. If you wanted to approximate an average of those two numbers, you could draw a line right through the middle of this curve to represent your CSS average. Okay? Because the concentration at steady state at the peak would be the CSS max. The concentration at steady state at the trough level would be the CSS minimum. Okay? And again, you're oscillating between those two values. When you think about this type of curve, really your goal is to maintain a steady state plasma level of the drug that is above the minimum effective concentration even at the trough levels, and that the curve is actually below the minimum toxic concentration, especially at the peak levels. In essence, what these two terms are defining is what's called your therapeutic window. You want to keep your curve on your rise to steady state in between these two numbers, inside this window, in order to be effective but not toxic. In terms of some tips about time to steady state, okay, the rule is this, that you get halfway to steady state in one half-life. You get 90% of the way to steady state in 3.3 half-lives. And importantly, and here's the one to definitely highlight, that in 4 to 5 half-lives, you're about 95% of the way there, which in essence is close enough because we call this clinical steady state. Okay? So one more time, it takes 4 to 5 half-lives for a drug to reach clinical steady state, and that's really the number that you must know. Important to distinguish also that clinical steady state is not the same as mathematical steady state. In fact, it takes greater than 7 half-lives to reach mathematical steady state. As clinicians, we're really not concerned about the mathematical time. We're really way more concerned about the time that it takes to reach clinical steady state. And in a particular question, with several pharmacokinetic values of a drug, one of those values that they will list would be the half-life. And maybe the question goes on to ask you how long it takes to reach steady state. Remember, the only value you're going to look at in that question to determine time to steady state is the half-life. What if you're told the half-life of the drug is 5 hours? Okay? If the drug has a half-life of 5 hours, 5 times 4, 20 hours, or 5 times 5 to 25 hours is how long it's going to take to reach clinical steady state. Okay? So just simply multiply the number by 4 to 5. Rest assured the exam is not going to give you both of those numbers, only one to ask you how long it takes to reach steady state. In terms of the rate of infusion, again, the time to steady state is going to be the same irrespective of the rate of infusion. Okay? It does determine the plasma level at steady state. So in other words, if you give more drug, you're going to reach a higher plasma steady state level. You're just not going to reach that level any faster than if you gave a lesser amount of the drug. A similar relationship can exist for other forms of drug administration, for example, oral. And again, you can reach steady state by any of a variety of ways of giving drugs. Doubling your oral dose can double the plasma levels of a drug, for example. So if you look at this particular diagram, what you should recognize is you're really looking at 5 different infusion rates. In fact, 5 different maintenance doses is what you're looking at. And those 5 different maintenance doses, obviously 1, 2, 3, 4, and 5 milligrams per minute. Again, plotting time versus plasma drug concentration. And what should you notice about this curve? You should notice that every one of these curves plateaus at the same time. They all level off at the same time. In other words, their time to steady state is the same, regardless of how much drug you gave, whether it was 1 milligram per minute or 5 milligrams per minute, all are going to rise and plateau at the same time. Now, I didn't say that these 5 curves are exactly the same. I just said that the time to steady state is the same. What is the difference in giving 1 milligram per minute, say, versus giving 5 milligrams per minute? Well, notice you're plotting versus plasma concentration here. If you give 1 milligram per minute, you're going to reach a much lower level in the plasma compared to 5 milligrams per minute. Okay? But you won't reach that level at steady state any faster than you did if you gave 1 milligram per minute. Next, we're going to look at the effect of a loading dose. Since it takes 4 to 5 half-lives to achieve clinical steady state, sometimes you just can't wait that long. It may take a long period of time to reach that steady state depending on the half-life of the drug, and that might be a situation where you want to use a loading dose. Now, a loading dose is designed really to more rapidly achieve effective drug levels in the blood, and it's really equivalent to giving a bolus of the drug, most often one time, a one-time only bolus. So it's estimated to put the amount of drug in the body that should be there at steady state. Of course, if the doses are administered at each half-life and the minimum effective concentration is equivalent to the CSS minimum, then the loading dose is twice the amount of the maintenance dose, and we'll highlight that. Okay? In our previous example, we were giving a maintenance dose of 100 micrograms per mil. So a loading dose in that situation would be double that amount, or 200 micrograms per mil. Again, assuming normal clearance and same bioavailability for maintenance doses. The equation here for loading dose is concentration in the plasma times the volume of distribution. And notice that we only have 2 variables that we're really concerned about here. The concentration in the plasma, which is our target plasma level, and our volume of distribution, which is going to help to predict exactly where the drug is going to go in the body. And you might be thinking that giving a loading dose sounds like a good idea really all the time. Why wouldn't you always want to rapidly achieve effective blood levels? And the answer is, of course, since you're giving a large bolus, it can be potentially dangerous. So you don't always want to use a loading dose because you are giving a large amount of drug, many times for the first time to a patient. So you want to reserve this strategy for certain situations, and one of those could be where it's maybe more of an emergency and you really can't wait that long to take effect. So if you look at this example, and I'm going to use the example of the drug digoxin. Okay? Digoxin has a half-life of almost 2 days. So you should be able to calculate that it's going to reach clinical steady state in 8 to 10 days, a long period of time. In fact, if you followed the graph here at the bottom, and let's imagine that this is giving digoxin only by maintenance dose, and this line represents the MEC, the minimum effective concentration. If you give digoxin only by maintenance dose, notice that the first dose doesn't even reach the MEC. Okay? So in essence, you've lost a couple of days right there. The next dose does get above the MEC, but it doesn't stay there for very long. And only until the third dose and the fourth dose will you start to get to plasma levels that are going to maintain a level above the MEC. Again, if it's a life-threatening arrhythmia, you can't wait that long in that type of situation. So that would be a case where you would want to use a loading dose. Okay? And if you gave a loading dose, most often that loading dose is going to be twice the maintenance dose. Its primary purpose is to give you a spike in the plasma, a level that's clearly above the MEC, so that the drug is going to start working and have its effect in the body right away. If you then follow that loading dose up with a maintenance dose, you can help to maintain plasma levels that are above the MEC. So importantly, if a loading dose is done one time, a one-time only bolus, if you only gave a loading dose, of course that plasma level would drop all the way back to 0. But if you follow the loading dose up with a maintenance dose, the combined levels of those two doses together can help you to achieve levels that stay above the MEC.